psoas adductors. That's the fascial line there. We have adductors that'll blend with pelvic floor, like they're synergistic to pelvic floor. But then we have the fascial line of adductors and hip flexor. And so again, we screen out adductor. You clear that out and it's like, wow, everything feels so much better.
This episode offers a lot of great information about pelvic health and its relationship to runners. We had some really great conversations. I learned a lot of new things, even about some bracing techniques for pelvic floor for female runners. Then we had some really good conversations about PSIS, lumbopelvic SI joint type pain and how to address it. And one of the key things that you should really be looking at and how this relates more than I thought to the pelvic floor, even though it's something I look at all the time. I didn't really always think about it in relationship to the pelvic floor, but if somebody's having that lumbopelvic SI joint type pain, there's some things that you should really be doing, addressing that to help get over that, as well as just treating diffuse hip pain and how that relates to the pelvic floor. So really great conversation, and I hope you take away from it as much as I did. Hi, everyone. Welcome to Run DNA podcast. Very excited today to have Dr. Liesle Elsey with us. And she's coming in and somebody that I've known for a while. We actually met at a course, and you were the participant in the course for the gait analysis that we did. And we had a really, I think I have that recorded somewhere, but you had a really interesting gait analysis. Do you remember that?
Well, and it's funny because I am half tempted to do a repeat of that gait analysis because now that I've been kind of refining some of those deficits that we saw to see a year later, because it was almost a year ago that we did so just to see kind of what it looks like, because it'll be interesting, right? How that carryover from a year ago.
From how it actually changed. It was, if I'm remembering correctly, what we were seeing is we were really looking at the pelvis. And it's kind of ironic because I'm going to introduce you and your background here in a second, but with your background and then what we saw, it's kind of like, do we gravitate towards the things that we need most? Because we saw some changes in your pelvic tilt that we were noticing that maybe we were contributing to some of the pain that you were having. Are you still having the pain? Or...
No, so that's the interesting thing. Like, I haven't been, so I've really tried to kind of clean up some of the mechanics using some of the drills that we talked about during the analysis. And I've been working on some of the mobility pieces. So that's why it'd be interesting just to see what it looks like on 3D again and do that side-by-side comparison to see what
that looks like. Yeah, very cool. So, well, let me give a little background here, and then we'll start diving in because I love that we're jumping right into it here. So, Liesle got her doctorate of physical therapy from Wayne State University, and then has spent a lot of her time in outpatient specialization, but she really has focused on pelvic health and the running athlete, which is why I'm excited to talk today, because I think it's important that if you're working with runners, everyone should have a great referral source of somebody that they can send to for pelvic health related issues. And understanding when somebody should send them and what that should look like is really important. So when she's not treating, Liesle is the general manager of her husband and 4 children, which we were just talking about track season before we got on, and how it's the general manager duties are high right now with your husband's coaching commitments there.
Totally.
It's a busy season this is spring of 2024, and it is peak track season. I think actually Penn relays start today, and it's just full on here with track, which is a fun time of year. But and then she also owns her own practice, and I want you to talk about the name of this. So it's a Gait Core Physical Therapy, right? And tell us the story of how you named the practice.
Yeah, so it's agate core therapy.
Agate. Sorry, my apologies. Yes.
No, and so so when you look at the name, it's like you just think that's how it's pronounced. But agate is a gemstone found on Earth, and it's one of the hardest stones on Earth. And a patient, and so how it came to be, a patient, my pelvic pain patient, I had worked with her, and she had such debilitating pain that she just couldn't do her just regular functioning tasks. And so we worked together, and she was, there's a proper term for it, but individuals who like clean up the stones and make jewelry out of them. And she had given me a necklace of an agate stone. And she just said, you gave me the strength I never thought I'd ever have again. And so that was really, and that was 7 years ago, she had given me this stone. And so it was really special to me. And so thinking about the concept of, when we're thinking about an individual, we want to have a strong foundation. And so coming from a pelvic health background, it's like, well, what do you need is a strong foundation? Like an agate stone is super strong, and we need to have a strong, stable foundation of our pelvic floor and our traditional core. And so thus kind of derived the name agate core therapy, because all of us, male, female, we need to have a strong foundation to be able to move through life. And sometimes that missing piece is hiding below.
That's awesome. Yeah, I love that story. I learned something about it. My kids love gemstones, so now I want to go get them that, but it's a great just parallel to what we do in the physical therapy field about natural movement and developing strength and solidifying the body, and how we increase the resilience so that we can go about the world and do what we want to do. So I really like it.
Yeah, totally.
All right, we have a topic we're going to talk about today, but real quickly, before, in case a lot of people listening are physical therapists or medical professionals, athletic trainers, chiropractors, MDs, but even for those people that aren't very educated about what a pelvic health specialist does, can you give us a quick overview of what the specialty really focuses on and why that might be different from seeing a traditional physical therapist?
Yeah. So, and it's funny. A lot of times when individuals fail like regular outpatient PT for back pain, hip pain, which we'll start talking about here in a second, is we'll see that pelvic floor therapist. So the pelvic floor therapist is going to have that knowledge kind of from all encompassing. So regional interdependence from head to toe. And so we want to have that foundation. So we do have the opportunity as an internally trained therapist to say, okay, let's take a look what's going on with pelvic floor. Is there a strength deficit? Is there a coordination that we need to work on? Is it that there's some upregulation? And so those muscles are actually honestly on all the time. And so when we think about muscles that are on all the time, they can't really perform in this dynamic aspect that we want them to be able to do. And so as a pelvic floor therapist, we have the opportunity to say, okay, where do we break down at? Is it the coordination? Is it the strength? Is it that we're just on all the time? And how can we kind of refine that so that we can have that strong foundation to be able to move through life and do what we want to do? So we get to put on multiple like lenses. So pelvic floor, our orthopedic, we can even go into a bit of like neuro component and just how our system kind of can be like rewired and kind of look at it, change the perception of it. But it's also like so many different aspects, and even diet. And so our gut health kind of plays into pelvic floor stuff as well, which I think so many times, especially now, a lot of people have sensitivities to your gluten, your lactose intolerance. And so what I find is that if they have a sensitivity that they don't really know about, that locally I'll feel a bit more of an inflammatory response. And so if I feel that locally, then we know that it's a bit more systemic. And then how does that influence their healing time too? When we think about like an Achilles tendonitis or like a patellar tendonitis, like those bursitis things that just kind of persist forever. So pelvic health kind of goes like a whole, like it's a big ball of things. And then we have to see those big things that kind of stand out and then kind of fine tune it so that they can do what they want to do.
I think it is fun, just because of the nature of my own practice. A lot of times you see people that have been to multiple providers before and haven't gotten results, and pelvic health therapists are very similar in that way. So they start to take a broader look at it, because you have to realize that there's more than just restoring mobility, restoring strength. There's more to getting healthy outcomes other than that. And I love how you put it there, that it's not just thinking about an internal exam. It's thinking about the whole person and thinking about their nutrition and the factors. I have a question about pelvic health in general here, and hopefully this isn't, I don't think it's an offensive thing, but why are people so bad at determining what their pelvic floor is doing? Like, why is it that like people just, they can't tell if the muscle's always on, it's always off? Are they just such poor perception of those muscles? Like, why are people bad at that?
Sure, but I think part of it is, I mean, some of it I think is generational. I think the newer generations are going to talk about those things. So talking about like peeing and pooping, like is it normal to like not be able to like poop phobias, not being able to poop in public, so you're holding on to it. Like, and I think so often we'll give ourselves excuses oh, well, I've always been like that. Oh, I always have to go to the bathroom. And it's like, well, that also comes from like a pelvic floor regulation and then habits, right, that we do. But also at the same time, like you come up to your friend and you rub their shoulders, like, man, your shoulders are tight, and they're still clueless. So I think that that's also an indicator, like, oh man, I have such a wicked headache. And then you come up to their shoulders, like, your upper traps are so tight. You're like, oh, I don't even realize it. Or even as a manual therapist, like you get a massage or something, and they're like, wow, what is that you do for a living? And you're like, yeah, physical therapist. Like, oh my gosh, maybe you should practice some self-care. And you're clueless to these things that have built up over time, over time, over years. So I think that's a piece to it. But then also putting ourselves in check. And so this is an analogy that I love to give every patient, is that our pelvic floor acts as like a puppy dog, right? So puppy dogs, when they're happy, they wag their tails, right? Their tails are wagging. They're so happy. They're happy to see you. But when they do something bad, they tuck their tails. They'll hide them. They'll hold them. And so just as humans, we express ourselves in similar manners. And so when we're feeling anxious and stressed, like we tend to like tuck our tails and just like hold everything. But not always do we want to recognize or have that mindfulness, like, hey, where am I right now? Do I need to take a minute and breathe? Or do I just need to like power through and just like get this done and just like suck it up? So I don't know that we always give ourselves grace to acknowledge our feelings. So that's just my opinion on the whole topic.
Good, right? Because I was being very generalistic in the question there. But it's true. We have the physical manifestation of stress and emotions, and it's very hard to be aware whether it's your upper traps or your pelvic floor. We don't get a memo that says, "Hey, we're on still." Like that's just your body adapts to these new normals very quickly, and that's why it's so important that you do see somebody that is trained in this, that it's not something that you can always just do self-care. Like your friend was saying, like, oh, you should do some self-care. It's like, I don't even know I needed self-care. That's,
Yeah.
it's the same thing as I always joke that, and I've had some professional runners on the podcast and say, well, why do you have a coach? Like, you know so much about running. They're like, yeah, but it's hard to self-assess. It's hard to know what you're doing and to not get out of your own head and do it. And same thing with movement and physical stress. You have to have somebody that is there to help you figure that out. So I think
Yeah.
everyone, I'm a huge advocate for the specialization. I think it should be something that everyone sees, especially certain populations like postpartum. I think that that's something, I know it's something, we've seen in my family that's made a huge impact. And I just can't thank enough the profession. And I'm glad that the topics are becoming more relevant, that people are starting to talk about, hey, it's not normal to be holding your poop in all the time. You have to talk about that stuff.
Yeah. Well, even the concept too, this past weekend, I helped crew an ultra relay, and we were just having the discussion about like, oh my gosh, I have to go to the bathroom. And there weren't always porta potties, and it was a 50-mile race. And so it's like, they're like, Liesle, don't even push me on this. I said, no, no, but like, you don't have to go to the bathroom. You're just feeling a bit naked, anxious. Like, you're going to be okay. And they're like, I just need to try. And so when I was like, see, I told you I had to go. I'm like, okay, they're like, otherwise I'll just pee myself. And it's like, all right, no team peeing. We're not allowed to have any type of peeing in our pants. Like, we don't need to normalize that. It's okay just to let urine run down our leg, or like to have feces running down our like backside. Like, yes, it happens, but is it normal? We don't want to normalize that we can, there is a solution to it. So I'll get off that soapbox there.
Right, yes. We could go probably into a whole soapbox on that, but I did want to talk about something similar but different, because I think there is a lot of attention. I love that there's attention to urinary incontinence and how that should not just be something that's swept under a rug. We should talk about it and we should find solutions to it. 100% behind that. I love that that's there. But I wanted to talk a little bit today about more hip and like low back, SI kind of pain there, and how that might have a relationship to the pelvic floor, because I think that this is something that people will often get frustrated with when they try traditional things for some hip pain or low back pain. And when they don't see a response, they get very frustrated thinking like, oh, well, I must need an x-ray. I must need an MRI, because clearly there has to be something really wrong with my hip. And then they inevitably get the MRI and there's nothing wrong with their hip. and then they feel even more frustrated. So can you talk a little bit about this diffuse hip, SI pain population, a little bit about, like, maybe we just start with, how do you know when your hip's not getting better, or based off of your symptoms, how would you be able to tell somebody that you're like, I'd really like to screen you or see you for some pelvic contributions to your hip or low back pain?
Yeah, generally, if so, for instance, if they have pain, so a lot of times, like, people have like a lacrosse ball, and they'll just like get at that spot, like, oh, this is where it hurts, and they rub at it with the lacrosse ball. They'll foam roll, Theragun, they might cup, and it gets better, but then it comes back pretty fast. Chances are there's like some piece of coordination with that pelvic floor. There's a missing link. So if they're doing all the self-care pieces, they're doing the stretches, it's like, okay, well, obviously there's something missing with that pelvic floor. There's that fascial connection. So pelvic floor, backside of the pelvic floor, deep pelvic floor, is comprised of piriformis and our obturator internus. So all of us in the PT world, we know like piriformis syndrome, like how that contributes to like SI pain and blah, blah, blah. But it also is part of the pelvic floor. So whose fault, whose fault is it then? Is it a hip instability component? Maybe they just don't know how to eccentric load the hip. So we go back to gait mechanics, like if my foot hits the ground, there's going to be this like slow internal rotation, then we're going to go into like the external rotation. And can the piriformis, can obturator internus like help shock absorb and do that rotation, the eccentric load, to like then have that like responsiveness? And so if they don't have that piece, it's like, okay, so then is it the hip's fault? Or is it pelvic floor who's like, hey, I need a bit of support here because I'm postpartum? So to kind of get back to that answer again, it's like, if it's diffuse pain, you massage it, you do the mobs all to the outside, and it helps, but it comes back, there's probably a pelvic floor piece there. So we have to see who's playing off of who. And it can go back and forth. Maybe it is piriformis and hip, but then pelvic floor's like, oh, I'll help you. And so now I'm just going to be tight. And then hip's like, oh, I feel great now. And pelvic floor's like, okay, well, now I'm holding tight. It's like, okay, now that lets go. And then now and so it goes back and forth. And so then you're just chasing that like diffuse hip pain and even SI pain for that matter.
Yeah, so is it compensating? Is it, or the main contributor to it there? And it's probably tough to tell unless you've historically been following somebody for a long time. So you probably, like, correct me if I'm wrong, and maybe there's other ways that you can tell chicken versus egg there, but taking a multimodal approach and saying, hey, when you're having hip pain, you should be paying attention to the pelvic floor, and if you're having pelvic floor pain, you should be paying attention to the hip too.
Yeah, and so the other screen too can be like, so say I'm just meeting a patient for the first time and we're chatting and they're like, oh, I'm coming in for some hip pain. It's like, okay, cool.
Yeah.
Well, let me go ahead, tell me a little bit about like pelvic health. Like, do you have any leakage when you cough or sneeze? No. Okay, cool. How about like, do you always go to the bathroom? Like, are you that person who has their morning drink, maybe they have coffee, and then they're going to the bathroom, or they're that friend that they goes to the restaurant and they're like, oh, I have to hit the bathroom. It's like, so they have that urinary frequency. It's like, okay, that's like a little bit of a red flag, like something might be going on there. Talking about bowel habits. Okay, can you go to the bathroom regularly? Yeah, I poop regularly. Cool. Like when we go to the bathroom, are we pooping grapes or bananas? A bunch of grapes or a smooth banana? And so it's like, okay, yep, I have maybe more grapes or bunches of grapes. Like, okay, maybe a bit biased towards constipation if we're having single grapes. It's like,
Mhm.
okay, so that's another indicator, something pelvic floor as far as tension. So urgency, frequency, and then a bit more constipation. So the clusters of symptoms, we'll see, okay, maybe some tension through the pelvic floor. And then for our female population, it's like, well, do we have any pain with insertion? So for pelvic exam, using menstrual products, whether that's tampon, menstrual cup, menstrual disc, and then pain with intimacy, with penetration. Again, if the answer is like, yeah, there's some discomfort there, and maybe it's been like that for ages, then we know history has already set them up to have some pelvic floor
Mhm.
symptoms that maybe they've just normalized over time. Um, for our men, again, I think they tend to have just more pain. So it can
Yeah.
be like their diffuse hip pain, and they'll still fall under the constipation-y stuff, like, and sometimes they're great. And so from that perspective, we just have to appreciate that, like, those will be the cluster of symptoms that will say, "Oop, pelvic floor first, then hip pain." Does that make sense?
That does. Yeah, those are good screening questions, I think, for people, whether you're a runner yourself and you're asking yourself those questions, or whether you're a physical therapist and you're asking some of those questions. I think those are good. And we have to be an advocate for our patients when we're working with them too. Say, okay, hey, we need to understand that you need to ask about these things. You need to ask about pooping habits and peeing habits, and that's okay. And it's okay to talk about that stuff. And those are maybe some screening tools that medical professionals can use when they're working with their patients to see if an appropriate referral or some other aspects or some low level things. Like, so when somebody is having maybe some predispositions to pelvic contributions here, what are some of the first easy things that they should really be focusing on doing?
Yeah, so I think if they're nervous about pelvic health, then we
Yeah.
screen out hips. So what does the hip do? Does it have good rotation? Does it not? Does it have good hip flexion? Does it not? So because whatever the hip does, the pelvic floor is going to be influenced by. So generally speaking, if we're talking from the outside, typically what I see in the outside, even in going into the low back, if we have some guarding through like the QL, or the paraspinals, and we're thinking about some SI pain too. We'll go kind of throw a little bit SI in there. And then you kind of screen down through like the glute tissue. It's like, wow, it's like rock solid on this side. Loss of rotation. It's like, all right, so let's go ahead and let's just screen this out. Let's give you some basic movement patterns to help screen out low back, improve some of the mobility, work on some of the hip flexibility, some of the hip mobility. Do symptoms improve? Do they not? If they don't, that's like, okay, so we've worked from like kind of screening things, clearing things from outside in. I have a really good therapist that could take a look at the pelvic floor. And sometimes if they're still a little bit hesitant, there is a way you can access externally just to get a gauge, like, what does their pelvic floor do? And if it's like, wow, so you know what? Based on my screening right now, it kind of leads me to believe there might be some more pelvic floor things that we might need to take a look at. Do you mind if I have you talk with blank? Because I think that would just be a great way just to even to educate you, and then that way you can make an informed decision. So giving them options, right? As a practitioner, you still want them to be able to make that decision and not feel uncomfortable about it, because in general, we talk about just experiences. We still want to have a positive experience about going into a pelvic floor evaluation. It doesn't want to be like, oh God, kind of like when we go to the dentist. I don't know if you have this opinion, like, oh my God, I didn't want to go to the dentist. And now it's like, you have to go to the dentist. And so we still want to be a positive thing. So you're not dreading going back there each time. We still want to be a positive experience. They have to make that informed decision.
Yeah, I think that's good. Even informing them, like, it's not always going to be internal exam work if that's something that they're experiencing pain with, and they're like, "Well, I don't want to be in pain a lot with this. I just want to get rid of my hip pain." But just saying that there are other things that they can do, and it's not all work with that, and it kind of works with those. So, what are some of the like key exercise, right? Like, or what should people focus on to really make sure that they're integrating core and hip function together? I've heard even just breathing techniques is a really important things of understanding when to what you're doing in the pelvic floor when you exhale, what you're doing when you inhale. What are some
Yeah.
good starter things if they don't maybe have a pelvic health specialist around there?
Right, totally. So, I mean, I think the first piece, so a lot of times we'll start with like breath. And so we want to see that the system can be dynamic. So if we're sitting here right now, and whether you're sitting, listening to this, or laying down, take a deep breath in and see what happens. So if we take a breath in and we say, okay, my chest rose up, it's like, okay, so that breath went through the chest versus going to the diaphragm. So diaphragm's 360 degrees. So we want to say we have the capacity for that whole diaphragm to be able to drop down. So sometimes the cue will be like, I want you to go ahead, take a deep breath in. And as you take that breath in, I want you to visualize that breath goes all the way down to the tailbone. So, okay, yep, I can feel that come on down. So we're knowing that we can get that backside of that pelvic floor to open up a bit. And so thinking about backside, we can think like obturator internis piriformis, and just saying, okay, well, there's our connection to our hip for any type of hip pain, SI pain. And it's like, okay, well, cool. Like I can work on that every single night. I can do this restorative breath and getting that connection. When we think about, okay, well, now do we have some hip mobility things? And again, going back to like our basic, like mean stretches that I love would be like a modified pigeon pose, right? Really getting that nice deep hip stretch, but making sure that it truly is refined to the hip, and we're not just like cranking our pelvis over the femur. And so now we're just like gapping that SI joint. Does that make sense?
Yes. Yes.
So we have to make sure that we're refining, because a lot of times people even get into like a figure 4 stretch and they'll just like crank on their knee, like, look what I'm doing. And it's like, oh, wait, pause. Like, let's just make sure that this is just like the hip is stretching and it's not kind of giving some type of abnormal pull or like a just imbalanced pull at the sacrum. So appreciating like we can have SI stuff from like, okay, our ilium moving versus like our sacrum. Does that make sense? Like relative motions.
Yeah.
And how that force can kind of interplay with one another. So working on the breath, like, can you have a dynamic pelvic floor? Yes or no? Simple question. Does it move?
Yeah.
Does it not? Then, what does your hip do? Do you have the ability to get that separation? And thinking about SI motion, it's like, okay, looking at hamstrings and quads, do you have, and this is my favorite, it's like doing the Run DNA screen, right? Forward bend. Can you touch your toes? And be like, oh, my hamstrings are so tight. And it's like, okay, first piece of homework, we're going to work on some hamstring flexibility, because we want to see when we do like drive our knee forward, we can get separation between glutes and hamstrings, like, and so that we're not getting this opening through the backside, which can generate some of our SI, like lower lumbar dysfunction. So again, flexibility, things that most runners will tell you, no, I don't stretch after I run. Like, of course you don't.
Or no, I don't do any weightlifting to actually go through functional mobility and use it. Of course they wouldn't, right?
No. So I mean, and I think that's the beauty about running, right? You can just lace up your shoes and run outside. But, and I think you have said this, I heard this at the symposium of the science of running, is that like you have to be fit to run. You can't run to be fit. So that, I mean, that was in 17, 14, I think 17, I had gone to Connecticut to that symposium and listened. It was like, yeah, that's 100% true. That's why you keep PTs in business, because you just go outside and think you don't have to do any type of mobility work or strength to prime the system to be able to run. So I think those are like mobility pieces and going to strength. And so when we think about strength, we have to think about, how does our system absorb that shock?
Yeah.
Does it not?
Where is the breakdown? Where are the forces? I've used an analogy of like a train stop before with it.
Oh, okay.
Where the forces acting on your body when you run are like a train going, and each joint is a stop along the train there. So what happens if you shut one station down, if you stop absorbing stress at the ankle because you have limited dorsiflexion, or your hip can't absorb some of the forces because of mobility restrictions or strength deficits? Well, all the passengers get off at the next stop. And then the next stop is overloaded, and there's like, this train station is a wreck because it's got all these people here. And it's the same kind of thing. If you shut down a stop along the kinetic chain, something else is going to have to take up that force there. So that's where, hey, the hip isn't working. All of a sudden, we're seeing SI low back kind of symptoms there coming in, which can be telling of maybe the regional interdependence of things and why we need to look at the whole body.
Yes. And that's like, if the ankle, and that's why a lot of times even like pelvic floor patients coming in is like, okay, well, I want to get back to running postpartum. And okay, so what's going on? Well, I had some SI pain while I was pregnant. So I was like, okay. And now I have some leaking. So it's like, okay, well, let's take a look at how, like, we'll start at the bottom. What does the foot and ankle do? And are we screening that appropriate for them? Because if not, that initial contact is going to be like, well, all right, we missed the bus there. We've lost it. So it will be. And sometimes to prove my point to patients, I'll say, I want you to go ahead and jump and pretend like you're, like, I want you to really like kind of let everything like accordion down, or like, I'll use the analogy of like a water balloon toss. I'll be like, I'm going to toss this water balloon at you, and I don't want you to let it to pop. Like, don't let it break. And all of us have been in a water balloon toss, right? And so we'll cradle that. We're like, oh, phew, that was close. And we want to be able to do that for our whole system, because we don't want to get wet. So like in the pelvic health realm, that's the analogy I'll use. Like, because if you're not shock absorbing, like, right? So so that, and same thing with like the SI pain. If we can't shock absorb, where is that shear force going to maybe go? Right up at that SI region. And like, ouch. And each step you take. And so, I mean, that's the cool thing with all of our fun devices like our Garmin's and our Coro watches. And it tells you how many steps you take when you run. And if you look at how many steps you take in maybe a 3-mile run, you're thinking how much of that force is getting lost in that SI joint because of a breakdown in coordination or strength through the system. And it's like, yowza, like that's rough.
That's a lot of stress on a single part there. So actually, like, let's kind of shift into that a little bit then too, because now we're talking about the running aspect of it a bit more. So you're somebody that is a pelvic health specialist, but you also do 3D analysis and you look at these movement patterns and you've, done all the training and you understand the movement. So where do you see pelvic floor dysfunction transfer into movement patterns, and how, like, what are you going to observe in the runner when you're seeing that, and how do you transfer some of these gains that you're talking about into changes in their movement patterns that really help to reduce some of the stress on the body?
Yeah, so I'll say, like, thinking like a case comes to mind right now, and it was she had incontinence, and but she also had some low back pain as well. And then previously, so probably, how long ago was it? Maybe like 15 plus years ago, she had a mastectomy, and so she had a quad deficit on that side. And so when we did the gait analysis, it was like, okay, yep, we know that there was a bit of a deficit. And even looking at the ankle, like that something was going on there. And so really working to clean up the mechanics of what we were seeing at the foot and ankle, at that knee. And the weakest link ended up being up and through the low back, because like everything beneath it wasn't really shock absorbing as we'd like to see. And then as a result of not being able to, so then the body, and this is my assumption, so like we make some assumptions like of how things come to be, like
Mhm.
hypothesize, if you will.
Yeah.
And it was like, well, okay, so she wasn't able to shock absorb, she had some weakness through the hip, and now we got the hip doing what it needed to do. And so then by way incontinence got better because we were able to load the system up. So from that aspect, it was like, okay, we looked at the ankle. Was the ankle able to go through any type of dorsiflexion?
Mhm.
Yes, no. Were we able to see that that knee could go through the appropriate like knee flexion moment? Yes or no? And then even I'm trying to think. I can't remember what I don't think that she could really get into proper hip extension because her ankle wasn't getting to extension, right? So then she was like a bit dumping. So hip didn't extend, but she could like just move through the pelvis a bit. And so years of running like that, it kind of, built up. So it's like a perfect storm. And so from a gait analysis, that you can see those breakdowns. And then the other one would be overstriding, like people putting on the brakes, right? And so and I think that tends to probably be the most common, what we'll see as far as like what is their category, if you will, like, oh yep, they're an overstrider and collapser. That's going to be like, mwah, pelvic floor.
Yeah, high forces can absorb what they're doing with it, and that's why we actually came up with the 12 categories instead of the 5, because we were seeing these, like, subcategories that were actually really helpful to understand what to do with people, because you say, "Okay, well, hey, you're overstriding, force is high. Then you're collapsing because your capacity is low." So it's kind of that perfect storm, an overstrider collapser. What are we doing with them there? And that's probably a perfect example for somebody with pelvic floor dysfunction, that they can't absorb some of those forces that are being imposed on them. And so you, correct me if I'm wrong, but you were kind of saying that, and this may be a good or bad thing from what I understood there, that when you change the stress on the body by doing gait analysis and reducing some of the forces, the incontinence will improve because it's not getting taxed as much.
Correct. That's my assumption.
You don't want to stop there, because the underlying cause for the incontinence is still there, and they need to address it. So you need to do both, because now the system will be able to recover better because it's not being assaulted as much.
Yeah, and that's again, it becomes an assumption because I think now we talk more about incontinence. So I mean, there's a lot of hacks that women will use. So for this individual, it's like, okay, well, if I were to, like, when I'm on my cycle and I have a tampon in, I didn't leak as much. And so That's why someone will use a tampon, but now Impressa has or Poise has Impressa, which is a similar device to give a bit of support. So it was like, okay, well, did we have deficits in our pelvic floor that existed because of postpartum? And we just were like, oh, well, I had kids, so I do have some leakage and whatever. And then that evolved into your hip and back pain. So it evolved into that. And so we have to think, okay, well, did we have a combination of both things? And then like one fed off of the other, and now it manifests into something that's just much louder. And so like the concept of like Shrek, you're an onion. We got, like I got to peel back the onions.
Yeah. Wouldn't though just like would doing that, like inserting, wouldn't that be kind of like back brace where eventually you're actually just reducing the use of your muscles and all of a sudden you become weaker? Would that have the same effect or?
It depends. So sometimes if a female, and we'll talk about females, if they're feeling this, if they're feeling the urge to go to the bathroom, then they put something there to give support. So that could be a tampon, that could be a menstrual cup, the Impressa, Revive is out there. If they have a pessary, then sometimes that allows their muscles not to feel like, ooh, I have to go to the bathroom all the time, or something's coming out of my body. And so then it allows the muscles not to be in this, I'll say, and this is probably not the right term that I'll use, but like a hypertonic state where it's just like always like, okay, I got you, I'm holding you. So it can go both ways. So whether they have something there to give them support, but sometimes they will, like you said, like a back brace, they can get lazy. And so that's why I always make sure that they understand the pelvic floor, whether you have something there to provide that support, it still has to be dynamic. Because at the end of the day, if you take that brace away, your muscles still have to be able to function. And if they can't, they forget how to do it and they become lazy, then we have a whole host of other like considerations that we need to think about. So it can go both ways. And I think that's important to remember. It's not just
Yeah.
one way always. Nope.
Well, it sounds almost like an orthotic strategy of you're going to shift the load for a little bit to allow the tissue to heal, but the idea is not long-term use. The idea is not to use these every time you run for the rest of your life type thing. It's like when somebody has medial tibial stress syndrome, that's when we might use an orthotic to shift some stress off of
Sure.
the medial aspect of the tibia and just give it a little time to heal. But then all at the same time, we're re-educating the plantar flexors and the intrinsic foot muscles, and we're teaching the body how to absorb stress appropriately so that eventually we wean off the orthotic and we get them back to normal running there.
And there'll be that caveat as we know, muscles don't always have as much of that tissue doesn't have that elastic principle. And so
Yeah.
sometimes like women, we need to have that sports bra on that's like a little snug. And so for women, we need to have that support. Sometimes if we've had birthing experiences that maybe are a bit more traumatic, or maybe we struggle with constipation. So we're always constantly pushing, which isn't, that's a whole nother topic. But so sometimes we do still need to have that support there, but the muscles are still going to be the first line of defense. And we have to remember that muscles are always going to be the first line of defense, that they can be smart, adaptive, responsive. And sometimes we need to have that little like internal sports bra, just give it a little boost.
Yeah, no, that's interesting. I hadn't thought about it that way. And I guess there's morphological changes, right? Just natural changes that we see over time. And I think our tendency is to always go for kind of like the agate stone, like you're saying, go for that, right? But eventually time even wears those down, right? And you might need a little help with some of those things.
Okay, yeah.
And we see changes. And when we do like an orthotic, I think people probably know I'm not a huge orthotic user. I don't use them very often for it there. But there are times when there are non-modifiable changes. And we have to kind of consider when we're incorporating equipment, is this something that we can modify? Can we get back to 18-year-old self with this here? Or no, we've had 3 or 4 kids and it's not going to ever be back to 18-year-old self. So we can make it much more manageable and enjoy the activities that they like by providing some support in certain ways. So that's yeah, it's interesting. It's I had never heard of these before, so this is kind of a new concept for me. So I appreciate hearing from the expert of like, okay, hey, what when would we consider that? Because it's not something that I've ever really even heard of, or I don't know if this is newer or if just my ignorance with it.
But I mean, again, I think women will come up with hacks. I mean, they'll just figure it out, and not always are they comfortable talking about it because,
Yeah.
and they'll be like, oh, and they'll be like, oh my gosh, I just this whole run, I just am completely soaking wet, and it's like, oh yeah, girl, me too, and it's they've normalized that it's okay, and at the end of the day, and I have to remember this too, is like, if you're okay with it, then I'll be okay with it for you. But I just want you to know that there are options that exist that we can make a difference. Whether it's bladder control, bowel control, SI pain, hip pain, there are options that exist in the world. We just have to match you up with a bit more knowledge. So it's always like one of those things. Remember, like just because it bothers you, Liesle, doesn't mean that it bothers them. So making sure you're not pushing off your beliefs onto them. But I just want them to know there are options. You don't have, this isn't the end.
Yeah, that's great. We talked a good bit about hip. Any other considerations from SI, lumbo-pelvic kind of areas there that we haven't touched base on yet?
Yeah, I think it'll become interesting. I think, and this will be bit more if there's tension, and this will be pelvic health kind of blended with orthopedic, is seeing what that the hip flexor does in the SI region. I love and I hate it, but I found that okay, if we have tension in through the hip flexor,
Yes.
then is it because of hip mechanics? Is it because of pelvic floor, right? So we have to visualize like iliopsoas comes down across like the backside, and then it comes into like attaches that lesser trochanter
Right.
to the hip, right? But beneath that in our pelvis, and we have iliacus, right, blends, we have pelvic floor that's like kind of adjacent to it. And so, and I, shame on me, maybe there's an anatomist that's dissected through the pelvis a bit more, but the fascial connections of how does the pelvic floor interface with hip flexor,
Yeah.
and then generate some of that SI pain. And so a lot of times I'll clear out glutes, make sure that they have a dynamic pelvic floor. But then if I have to go in and release their hip flexor, it sucks, but it helps with the SI pain so much. And especially for men, like, sorry, husband, but like with my husband, like his hip bothers him. And it's like, okay, we'll work on these things, hip mobility. And then I'm like, you know what I have to do? He's like, oh, not the psoas release. I was like, sorry, here I come.
It's funny you say this because literally, we were kind of talking before. I had like I had a good workout earlier in the week, and then I had some hip pain after it, and I had a little bit of like adductor, glute, and SI kind of pain. And I lay down, and I work on my hip flexor, and it's like, okay, all of it goes away. It's like I didn't touch any of them. Yeah.
So as the fascial connection, so if you go to like Thomas Myers Anatomy Trains, the fascial line, psoas adductors, that's the one, like that's the fascial line there. So when we think about screening things out, and we know from also like pelvic floor is adductor. So right, the different fascial lines, depending on how nerdy people are who are listening right now, like the fascial line. So we have adductors that'll blend with pelvic floor, like they're synergistic to pelvic floor. But then we have the fascial line of adductors and hip flexor. And so again, we screen out adductor, like an adductor, like sometimes you get in there and it's just like, it's gritty. It's
Oh
super
yeah.
gritty. Ugh. But you clear that out and it's like, wow, everything feels so much better. And so, it depends, which was it? Was it the hip flexor who maybe isn't able to go into extension because maybe your calf was a bit tight? You don't, like, we can make all these assumptions as to like, why did this happen? And so as we're seeing people in person, like being able to like lay your hands, where do they break down? How does that affect like the fascial line? But yeah, so it's another tangent, but yeah.
Even like I find the same thing. It's funny you say that because I've always found if somebody's having this one-sided low back pain, I have to check the hip flexors. It's going to probably be involved in that in some aspect here, especially in more like SI type pain. And I don't, this is Definitely a soapbox here, but something I found, and a tangent here, a lot of people address the like the iliopsoas closer to the hip and from the front side. I go to the back. And I go in and loop around from the back and get on the proximal origin as much as I can there. And I find if I can get in on that aspect, that gets much better, longer lasting results because when you just address the insertion as opposed to that, you're not really getting the whole picture, and you have to get up actually at like the lumbar spine attachments there, and you can get it. Yeah.
You are far kinder than I am, because I'll just walk my fingers up the abdomen
Yeah.
and get into the, yeah. So, but so look,
They
I'll
don't feel
be,
very like I'm being kind when I'm on it there because it's so painful, but yeah, it's
so
a good positioning.
totally,
Yeah.
you have to screen out the whole psoas muscle, like you do. And I mean, and it's also a reminder to, like, doing talks like this, teaching, is it's a reminder to ourselves, like, origin insertion, we have to clear out the whole muscle. And so I will go, like, and I'll put them up into flexion to do like a bit of like a counter strain, a bit of a moment there, but just see, like, can I in fact get into that, the like proximal part. And so I'll tie this back into like pelvic health here. Psoas has fascial connections to diaphragm. Cool, right?
Yeah.
So if hip flexor is like stuck, then does that like make the diaphragm bit gucky? So now you got to take that deep breath in from, like, posterior diaphragm. Can it move? Can it move? Maybe not. Maybe we've never taught it to be able to do that. And so if we can work on doing some of like that deep breathing, so to work on like posterior diaphragm, getting to child's pose. If you need to put a pillow like on your thighs to help give you a bit more of like that, like arched position, so you can really breathe into the back. Does that allow that connection of hip flexor, so psoas proper, interface with the diaphragm? Does that allow that to move? And like we'll go to like posterior side, like QL, and how it's like on the back side. Do we see like, okay, yeah, now that can like open up, and kind of now we can have that diaphragm give input to the pelvic floor to say, hey, pelvic floor, we're buddies, we need to go places together. If I take a breath in, that pelvic floor can lengthen. As I breathe out, it can come back up. It's nice and dynamic. Super. Like, we have that dynamic motion. But if it can't be dynamic, if it can't adapt and kind of meet your needs, what's going to happen? And that's why we come in for diffuse back pain, hip pain, pelvic floor dysfunction, urgency, and all those fun things. So we make assumptions, but yeah, you have to screen it all out. It's all connected.
It is, and this is the fun part about, like, being in the medical field. There's so much to learn, and I gotta give a shout out to, like, JJ Thomas, who taught me. She showed me how to needle, like, proximal, hip flexors and how to do that. She's got, like, a master class on needling that I recommend anyone that needles, like, takes, because then I started even doing it just with hands-on as I was gaining confidence with the needles, and like, getting in there, it makes such a huge difference, and our whole goal, like, one of the things when you treat runners is you don't want to tell them not to run. So if you can get their pain down as quickly as possible and restore their movement, they're going to be much more engaged with the treatment, and they trust you a lot more. So you have to know these kind of things about treatment and how to get results quick, because that's going to be able to get you much more trust for them. So yeah, I love your perspective on it, even with the diaphragm and how that all comes in. And I'm glad we went this way with it there, because it was like I'm glad we were able to tie it in even pelvic floor, because it does, like you're saying too, the adductors, you have to look at that stuff, you have to look at those things. But I try to always think about, well, what's the one thing, like what's the epicenter of it there, and what's really causing it, where if you can work on this one spot, all of a sudden the adductors and the hip adductors and hip abductors as well are just going to loosen up. And a lot of times that's hip flexor. It makes a huge difference with it.
It does. Well, and that's the other interesting I was just thinking about is when we think about even just like diffuse pain, so a bit away from like the low back pain, but it's still kind of in the pelvic girdle, is that we'll have nerves that kind of traverse through that psoas muscle that can kind of give us some saddle groin pain. So what we can identify as like, ooh, it's my groin. So as I think traditional orthopedic therapists were like, groin, hip. And it's like, is it hip or is it psoas? Or is it nerves that are being compressed through the lumbofascial connection that are giving us, mimicking some of the saddle pain, groin pain, and it's diffuse. And so we're kind of chasing it. So, going back to like PT school, and we learn all the nerves and what they innervate, it's kind of like, okay, but also sensory, like and that's one thing that going back to nerve innervation, is very humbling, because in PT school, you're like, your brain's like exploding. When am I ever going to use this information? It's like, oh, trust me, once you've had time to reflect, you will. And so from that junction, you'll see that can be just like diffuse saddle pain. And I'm part of GFAM, so Global Pelvic Health Alliance membership. And so they have this beautiful picture of how the interface of how the nerves kind of influence and kind of play into the pelvic region. And it's such a cool image. So like, shout out to the illustrator who has done those, because we can see how what we might assume is maybe it is hip, but maybe it's coming from the lumbar region. But is it because our hip flexors tight, or is it because the dynamics of our pelvic floor aren't as dynamic as we want them to be? And so again, which comes first, the chicken or the egg? You don't know. But sometimes if we listen to our patients, they will tell us. They will tell us. We just have to like listen, and not always. I'm guilty of this. Not always do we listen. We hear, but we don't listen.
Yeah, that's a huge part of it. And it's fun. It's putting all the pieces together. And I love how this whole conversation really has continued as it started, as saying we have to look at the whole. We have to look at this. And I think that pelvic health is that piece that oftentimes isn't as looked at. And I love that it's gaining popularity. And I love that it's getting to be more of a common thing that's talked about, more that it's a common treatment sought after. So kudos to the profession for going that way here. And so I feel like we could keep talking about lots of other fun, different things too here. But in the interest of time, how can people find more about you? Like, what's the best way to connect with you if they want to keep going with some of these conversations, or they think they need some help themselves? Like, how can people get a hold of you?
Totally. So on Instagram, I'm at dr.Liesle Elsey. So LIESLE.ELSEY. So I'm working on trying to build that platform. It's just gaining knowledge. And so I think as most individuals, we just want to be a resource to people. So you can find me that way. You can email me through Agate Core Therapy. Honestly, any question that people have, I'm happy to continue this conversation. If like, I want you to teach me more, absolutely, I can do that. So yeah, I think that's, and even so that'll probably be the best way, through like Instagram is probably your best way. Things always get lost.
This has been great. It's really been a pleasure just chatting with you and hearing. And I love, the multimodal approach, but also relating it back to the running form too, because I think that that's interesting, and a different specialty within the specialty of how we can look at that and see that we do need to address this, and that gait analysis may be a critical function of addressing these incontinence issues and addressing hip pain and low back pain in females and runners, and maybe even with walking. Like we do a lot with running, but same thing with walking, and looking at their mechanics and how we're absorbing those stresses. So I think it was a really cool perspective.
Thank you so much this was an awesome conversation. Like you said, we could talk about this 4 hours probably.
Yeah. But thank you for being on, and thank you everybody for listening. Happy healthy running. And until next time, if you want to hear more, you can also head over to rundna.com, sign up for the newsletter, find out about other webinars and events and courses and things that we do. So thanks for your time today, and have a great one.
Like what you hear? Leave a review of the show wherever you listen, and don't forget to subscribe so you never miss an episode. RunDNA helps runners and running specialists through education and technology to identify each runner's unique injury profile to avoid setbacks and maximize results. The RunDNA podcast is produced by Ace Running LLC. The RunDNA podcast is intended for educational purposes only. No clinical decision-making should be based solely on one source. While care is taken to ensure accuracy, factual errors can occur. Always seek the guidance of qualified medical professionals before making healthcare decisions. Find us online at rundna.com.